inflammatory conditions, and varices. Instruct the client to take nothing by mouth for 8 hours prior to the procedure. Also, be sure the client signs a consent form. If the client has dentures, remove them before the procedure. The client will be given a sedative and a local anesthetic will be sprayed on the throat before the examiner inserts the endoscope. Explain to the client that the anesthetic will calm the gag reflex. Following the procedure, keep the side rails up until the client regains full consciousness. Give the client nothing by mouth until the gag reflex returns. To test for the gag reflex, tickle the back of the client's throat with a cotton swab. The gag reflex usually returns within 2 to 4 hours. It is important to check the client's temperature every 15 to 30 minutes for 1 to 2 hours following the procedure. Notify the primary care provider immediately if the client's temperature suddenly spikes. A sudden elevation of body temperature might indicate perforation. Other signs of perforation include pain and bleeding. Caution the client to avoid driving for 12 hours following the test. Advise the client to gargle with a warm saline solution or to use throat lozenges to relieve the sore throat likely to result from this procedure. Other diagnostic procedures include upper gastrointestinal X-rays, gastric analysis, and examination of the stool for occult blood. A biopsy may be necessary to determine whether an ulcer is benign or malignant. Management of peptic ulcer disease focuses on pharmacologic therapy, non-surgical management that includes diet therapy and lifestyle changes, and, in some cases, surgery. Medications used to treat peptic ulcer disease include antacids, given 1 hour after meals to neutralize gastric secretions, help relieve pain, and prevent bleeding. Other medications are antibiotics to treat the H. pylori infection, anticholinergic drugs like propanthyline, that's probanthine, or dicyclomine, that's bentyl, given before meals to reduce gastric motility. They also include the H2 receptor blockers or antagonists, cimetidine, that's Tagamet, or ranitidine, that's Zantac, given before or with meals to decrease secretion of gastric acids, and mucosal barrier protectants like sucralfate, that's Carafate, to help form a protective coat at the ulcer site. The client who is hemorrhaging might also need a blood transfusion. Non-surgical management of peptic ulcer disease involves teaching the client about major lifestyle changes. Instruct your client to stop smoking and avoid drinking alcohol and beverages containing caffeine. Also teach the client to avoid spicy foods and meals that are high in fat. It is also important for the client to reduce stress and learn relaxation techniques. Some clients who have peptic ulcer disease require surgery. Now we'll turn our attention to cirrhosis. Cirrhosis is a progressive, degenerative disease of the liver. Liver cells are damaged and replaced by fibrous, connective scar tissue. As a result of the damage, the liver is unable to carry out its functions. Normally, the liver produces bile, which facilitates the digestion of fats, converts glucose to glycogen, stores glycogen, which is needed for energy, synthesizes albumin, amino acids, globulins, prothrombin, and fibrinogen. Converts ammonia to urea, stores fat-soluble vitamins A, D, E, and K, plus vitamin B12, copper, and iron, and forms lipoproteins, phospholipids, and cholesterol. A major cause of cirrhosis is chronic alcoholism. Alcohol-related cirrhosis is called Leydig cirrhosis. Older clients who chronically ingest large amounts of alcohol have an increased risk of developing Leydig cirrhosis. Other types of cirrhosis are biliary cirrhosis, which is caused by chronic biliary obstruction, post-necrotic cirrhosis, which can be caused by acute viral hepatitis, drugs or environmental toxins, and cardiac cirrhosis, which is a complication of right-sided congestive heart failure or chronic constrictive pericarditis. What are the major signs and symptoms of cirrhosis? Abdominal pain, enlarged liver, enlarged spleen, anorexia, nausea, and vomiting, indigestion, anemia, jaundice, and itching, ascites, caput medusa, liver flap or hepatic tremor, constipation or diarrhea, dark urine, hypoglycemia, varices or hemorrhoids, spider angiomas, and a fruity or musty breath odor. The diagnosis of cirrhosis is based on these laboratory studies and diagnostic procedures. Liver function laboratory studies. serum ammonia levels, CBC and platelet count, coagulation studies, prothrombin time, serum electrolytes, MRI, CT scan, radioisotopic liver scan, and liver biopsy. Cirrhosis is treated non-surgically and surgically. Because diet as well as fluid and alcohol restriction are important aspects of non-surgical treatment, the client may benefit from instructions from a dietitian and a nurse. The dietitian can make suggestions to help the client to still enjoy food while remaining comfortable, while the nurse can talk about the importance of fluid and vitamin intake and the need to avoid alcohol. Medications are also used to treat cirrhosis. Diuretics help eliminate excess fluid, which improves the client's respiratory and cardiac function. Low sodium antacids help control chronic dyspepsia. Vitamins and nutritional supplements are also useful. However, remember that clients who have liver impairment, especially elderly clients, must avoid drugs known to cause hepatotoxicity. The liver metabolizes most drugs. A damaged liver cannot metabolize drugs properly, causing adverse drug effects. Clients with liver damage should avoid sedative and opiates. Other interventions include weighing the client every day, recording intake and output, monitoring electrolytes, measuring the client's abdominal girth, and providing opportunities for adequate rest. A paracentesis should be performed when diet and diuretic therapy fail to control the ascites, and the client develops dyspnea. During a paracentesis, the physician inserts a trocar into the client's abdomen to drain the acidic fluid that has collected in the peritoneal cavity. To prepare the client for a paracentesis, assist him to a sitting position on the side of the bed or in a chair with his legs and feet dependent. If the client is unable to assume that position, help him into an upright sitting position in bed. Ascites fluid should be removed slowly.